Welcome. Welcome to this PCR webinar, A Patient with In-Stent Restenosis. What is the role of drug-coated balloons today? My name is Andreas Baumbach. I'm moderating this DCB webinar series, of which this is the second. We had talked about drug-coated balloon as a first choice for patients with de novo lesions earlier, and this is available online. On the 11th of December, there will be a DCB digital crosstalk talking about practice patterns across the globe. This series is sponsored by an unrestricted grant by Concept Medical. I'm in the studio today with Dr. Fernando Alfonso from Madrid, a super expert in the field, and Dr. Azim Latib is joining us from Rome, but of course he is originally from New York in the United States, an innovator and absolute expert in the technology and clinical application. Before we begin in earnest, just let me remind you that you can participate. There will be a poll, and I'll introduce the question in a moment. The poll will be later, and we'll do one at the very end to see whether you changed your mind. The poll is accessible, like you see here, through the chat. And you can also ask questions, which we will try to answer in the chat. You can also send nice comments like hello from Uzbekistan and Kenya has just come in. So the polling question will be, not quite yet, but will be, DCB should be first choice over DES for in-stent restenosis. Let me ask my experts here. Fernando, what's your?
Well, my answer is yes, but I will individualize.
Individualize. And Azim?
It's a resounding yes from me as a first choice, and hopefully by the end of this webinar, we'll have convinced most of you why we think so, or why I think so.
Excellent. So, drug-coated balloons, a long history dating back really to the days when we dealt with local drug delivery up to the first DCB in 2006, CE marking. And 2024 is really a year where DCB for in-stent restenosis gained approval for the first time by the FDA in the US. But it's also the year where the guidelines changed in Europe, and we will discuss both issues and the implications for us at the end of this hour. There remains a lot of questions, really. There's a wide variation of practice. The leave nothing behind mantra is behind it. There's evidence for pro and for con. There are cost implications, and there's a large range of DCB systems. Here, the ones that are currently available, different manufacturers and different drugs and different polymers. The main objectives of this series is to define the concept and mechanism of DCB, to summarize the key clinical studies, to evaluate the advantages and limitations in practice. We will try to make this practical. We want to analyze real-world cases, review how in-stent restenosis occurs and how DCB can address it, and discuss the effectiveness and evidence for DCB in managing in-stent restenosis. So today, we want to review mechanisms, discuss the role of DCB in treating in-stent restenosis, and review the evidence. Now's the time for the poll. The question you should answer yourself and to us, DCB should be first choice over DES for in-stent restenosis. You can vote now, and I'll leave it on, and I'll give you an update about the incoming votes as we go along. At the moment, it's a resounding yes. And we'll move a little. And whilst we wait for the rest of the colleagues to give their vote, this is the webinar today. My introduction is over. Next up is Azim with a clinical case then Fernando with the evidence. We'll have time for question and answers, and we've got a separate 5 minutes or 10 for the guidelines until we do the final poll. So it stands at 87% for DCB should be the first choice over DES for in-stent restenosis. So we have 13% of our colleagues to convince. Azim, over to you.
Great. Thank you, Andreas. And it's a real pleasure to talk to everyone about in-stent restenosis, which I think is probably, one of the first applications we've all become familiar with using a drug-coated balloon. So I often hear said, particularly in the United States, that, in-stent restenosis is not an issue anymore, but I would like to argue that. Here's some data published by Issa Musa and Jack in 2020, looking at the NCDR database, which is a large database in the United States that collects all the PCIs being performed. And in that database, you can then go look at specific factors. And so they looked at over 5 million PCIs being performed from 2009 to 2017 and found that 10% of PCIs in the US are being performed for in-stent restenosis. I mean, that means 1 in 10 patients you're seeing in your lab has restenosis and needs treatment for it. Obviously, we've seen a decrease in ISR or BMS. Most of us see very few BMS anymore that maybe were implanted many years ago, but that's declined significantly. But what I thought was interesting in this data is that despite the introduction of newer generation drug-eluting stents, if you look at the rate of ISR, it's really not changed. It's stayed pretty constant. And so, it's not like ISR has disappeared. I think we continue to see it as a clinical problem. Hopefully, we can talk today. Some of the things we'll mention about treating it will also hopefully help prevent the first restenosis. The other thing I think that we all agree is that in-stent restenosis is not benign. It's not something that just happens, patients come in and we find it as an angiographic finding. I think there's more and more data, and here's one of them showing that patients with in-stent restenosis often present as an acute coronary syndrome, either as unstable angina or as an NSTEMI. And that patients who have restenosis, their outcomes, if you look at things like death, reinfarction, and target revascularization, is 2 times higher than when you treat de novo disease. So what are some of those predictors of stent failure that we see? Well, there are patient-related factors, and the ones that come out particularly are things like diabetes and chronic kidney disease. Then there are lesion-related factors, such as treating a bifurcation, especially when you implant 2 stents in a bifurcation. Smaller stents, longer stents, treating graft lesions are all associated with a higher risk of stent failure. And then there are procedure-related factors, and those are the ones that really are in our hands as interventional cardiologists and that we can do something about. And so things like undersizing our stents, malposition, not fully expanding the stents, geographical miss, not covering the entire lesion, implanting very long overlapping stents or edge dissections are all factors that we need to take into account. Often, though, it's multiple factors involved that result in stent failure. I think one of the other factors that I think we need to remember is that patients who get restenosis are at higher risk of getting it again. Right? It's sometimes impossible to correct it, but that's what we have to try and do. We have to try the first time we treat a restenosis to get the best possible result, because those patients are at high risk of coming back, of what we call sometimes frequent flyers, the patient who comes back every year because they're restenosing again. So I think for all interventionists, it's really obligatory on us to try and get the best first result. So we prevent it, but when we treat restenosis, to try and get the best result possible. So let me take you through a patient and tell you how I evaluate patients with restenosis and take into consideration how I treat these patients. So this is a 52-year-old patient who 3 years before had a PCI with a drug-eluting stent, on the LAD, presents now with recurrent chest pain during exertion, had an exercise test that was positive for ischemia. Here's the angiogram of the left side. I'm not showing you the right side. The right side was fine. And you see this long stent in the LAD with really diffuse in-stent restenosis. So I would really encourage all of you, our colleagues, that when you see restenosis, really it's when you need to think about pulling out your IVUS catheter or your OCG catheter. If, this is probably one of the best and most important indications for me for intravascular imaging, because you really do need to understand, why did your stent fail? You put a stent, and we all try to put stents in the best way possible. But if we use, stents, which are the best technology we have to prevent restenosis, and they fail, could there be a cause that caused that restenosis that we could then correct to prevent it from happening a second or third time? So, pull out that IVUS catheter, OCG catheter, understand what is the mechanism of restenosis. Is it neointimal hyperplasia, or is it calcific neoatherosclerosis? Maybe that stent was undersized when we put it in. We put it in the setting of a STEMI, and we didn't want to embolize material distally, so we didn't fully expand it. Is it malopposed? Is it underexpanded? I think look at all those factors. Could there be a stent fracture? So think of those factors, and the only way to really understand that, you can't understand that angiographically, you really need intravascular imaging in order to be able to understand that. So yeah, just showing you again, as we're looking at the imaging, really trying to understand where's the stent, what is intimal hyperplasia, is the stent well expanded, where's the external elastic lamina, as you see in the stent undersizing part, or in the stent under expansion part. Really spend the time to understand what the mechanism of restenosis is. So in our patient, we did that. We did imaging. I think there was a little bit of underexpansion, but really not a lot. But we could, if you look at the picture on the bottom right, possibly expand the stent more. There was a lot of intimal hyperplasia, though. I don't see calcific neoatherosclerosis in this picture. And so already I'm thinking in my mind, not only one, what's the mechanism, but also two, how am I going to treat this? How am I going to get the best result possible? Because certainly whatever you do, whether it's put in another stent or avoid a second stent layer and use a balloon, a drug-coated balloon, you really need to get the best possible result from lesion preparation before you do that. So when I look at this kind of lesion, I'm already thinking maybe I can get away with a non-compliant balloon only. If I'm going to use DCBs, I also like scoring or cutting balloons, and I'll discuss that in a moment. So this is my approach to restenosis. It's really, and we published this together with a lot of colleagues in our consensus article. It's really try and get optimal lesion preparation. And what that means, it's good pre-dilatation. And I call it do POBA the old-fashioned way, a way that many of the younger colleagues never learned, but I got to learn from my mentors, and I'm sure you can from yours too, is really you got to do good pre-dilatation, even if you're going to use a non-compliant balloon. I generally only use non-compliant balloons for this. I try to do a balloon vessel artery ratio 1:1, and I do longer balloons, not very short balloons, and I do long and repeated inflations. I sometimes will inflate 1 to 2 minutes to try and make sure I have a good result. I think if after that you still don't have a good result, then think of specialty balloons, such as scoring or cutting. Do you need atherectomy, laser, or lithotripsy? And also, you really need to figure out how you're going to assess that you got a good result. Is it going to be functionally or using intracoronary imaging? Once you get an acceptable angiographic result, but what does that mean, an acceptable angiographic result? It means residual stenosis less than 30%, no flow limiting dissections, and if you're going to use functional evaluation, an FFR of greater than 0.8 or an RFR greater than 0.9. Only if you have a good result should you then think of opening your DCB. So when I'm working in the cath lab, I don't just immediately grab for my DCB. I first prepare the lesion. I do a really good job of preparing the lesion only when I have a good result, which is, again, less than 30% residual stenosis, no flow limiting dissections, do I then open the drug-coated balloon? Is that important? Is there data to support that? Yes, there is. So this is a retrospective study we published a long time ago where we looked at all 166 ISR lesions that we treated with DCB while I was working in Italy. And we divided the lesions into whether we got an adequate or good angiographic result or an inadequate result. So an adequate result was, like I said, TIMI-3 flow, residual stenosis more than 30, and no major dissections. Right. And when we got a good result, our event rate was much lower. It was 26.8% versus 41.5%. So getting an adequate result really helped. And this, in most of these cases, we either used a non-compliant balloon for pre-dilatation, or we used a cutting balloon or scoring balloon to prevent, slippage, that sort of Melancening effect that you sometimes see with balloons. Here's another paper, again, by another group of colleagues from Korea, looking at 256 ISR patients. And again, the bottom line, the line with a lower event rate, were patients who had better preparation, so lower residual stenosis, patients in who you selected the correct DCB size, so at least as close to 1-to-1 as possible. And interesting, and I like the last one, number 3, patients with longer DCB inflation. So the longer you left the balloon, the better the outcomes, right? So again, good lesion preparation, choosing the right balloon, leaving it inflated for the right amount of time. So that's what we did in our patient. We used a non-compliant balloon at high pressure. For me, high pressure is at least 18 atmospheres or higher. We weren't really happy about the proximal segment, so we went with a cutting balloon at high pressure. Again, I usually tend to undersize my cutting balloons when I go at high pressure, so this was only in the proximal segment. And when you look at the angiographic result, it looks good now. There's no residual, there's no dissection. The residual stenosis looks less than 30, and there's TIMI-3 flow. I like using scoring or cutting balloons in these patients because I think it allows you to have controlled dissections through the neointima and neoatherosclerosis. It results in more, I think, dilatation power, more acute luminal gain. And I also think it allows for better drug transfer. There's some data to support that, preclinical data. After you've done your preparation, if you want to do IVUS to assess the result, I think now's the time to do it before you use the drug-coated balloon. Because if you don't like the result in IVUS or an OCT, you should continue to do the lesion preparation you feel adequate to get a good result. And the things we're looking at on imaging are no major dissections, and really that the residual lumen is as large as possible. So here you see a much larger residual lumen. You see the stent is well expanded. There were no dissections, so that would be a good result, right? So reassess the lesion preparation, reassess your lesion prep with imaging before you use the drug-coated balloon. And here again, just going through again, what are you trying to assess? Did you get a good result? Have you adequately modified or cracked calcium if this was calcific? Did you get optimal stent expansion? Is the stent as large as it's going to be? So you're kind of doing everything you need to do before going with the drug-coated balloon. Then when you like that result, the last thing you do before doing a final angiography is use a drug-coated balloon. Because remember, there's nothing special about drug-coated balloons. It doesn't have special dilatation powers or anything. It's only a drug delivery device. So you want to use it right at the end when you think you're done with the procedure. My advice, use long balloons. I tend to keep long balloons in my lab. You inflate it to nominal pressure and keep it inflated for 60 to 90 seconds at least. The longer you can inflate it, the better. After I've inflated it, I give some nitro and I do my final angiogram, and hopefully that's what I want to get. So really, my advice to the colleagues, if I can summarize it, is use intracoronary imaging to try and understand what is the mechanism. Did you get a good result? Do optimal lesion preparation, okay, which means get less than 30% residual stenosis, TIMI-3 flow, no dissections. And then think the balloon is just a drug delivery device. Get it to the lesion as quickly as possible, inflate it for at least 60 seconds, and usually it's the last thing you do before doing your final angiogram. Andreas, over to you.
Fantastic. Thank you very much. That was a really great introduction to the field and a demonstration on how you do DCB for instant restenosis. Questions are floating in, but I think we continue with the second talk and then have a large question and answer section after that. That means, Fernando, over to you. How do they work and what is actually the evidence?
So first of all, thank you for the invite. It's a pleasure to be here and a real pleasure to be discussing this important topic with Andreas, with Asim, and also with all of you. As Asim was explaining, despite the use of drug-eluting stents, in-stent restenosis remains a major problem, and this is the rate of procedures in the US, as we've been discussing, coming from large administrative data set, suggesting that 10% of PCI procedures in the States are in fact addressing the problem of patients with in-stent restenosis. Some years ago, we performed this small survey on official national data. In Europe, the numbers are a little bit different. So roughly in Europe, 5%, this is 1 out of 20 procedures in the cath lab are addressing a patient with in-stent restenosis in Europe. As we all know, historically there has been many interventional modalities trying to address this problem, but today we will concentrate and we will review the data suggesting the value of the two main strategies, either drug-eluting balloons, drug-coating balloons, or drug-eluting stents. So for the last 25 years, I have to confess, we've been having interest in this issue, in stent restenosis, and with the RIVS trials, registries and randomized clinical trials, many centers, 25 centers in Spain, we were addressing different strategies, plain balloon angioplasty, bare metal stent, drug-eluting stents, and as you may see in the last 15 years, we try to assess the value of leave nothing behind strategies, mainly with drug-coating balloons, but also with scaffolds. So, the story started with this important, seminal, pivotal, randomized clinical trial, but notice that only 52 patients were randomized. So it's a beautiful work by Bruno Scheller, demonstrating the drastic reduction in late lumen loss and in restenosis rate when paclitaxel-coated balloon were compared with POVA in patients with bare metal in-stent restenosis. After that, this is data coming from Munich, where they compare a first-generation drug-eluting stent, this is paclitaxel-eluting stents, with paclitaxel-eluting balloons and POVA. And as you may see here, in the late angiographic findings, the two devices using the drug, as expected, had much better late angiographic results. And another study, again coming from Munich, demonstrated that if we want to use a drug-coating balloon for ISR, if we predilate the lesion with a scoring balloon, the late angiographic findings can be significantly improved, as is detected here. So these are the 25 sites that helping us in Spain to do these two major randomized clinical trials, RIS4 and RIS5, basically comparing drug-eluting balloons versus everolimus-eluting stents in patients with in-stent restenosis. Now, RIS5 is patients with bare metal in-stent restenosis, and it is quite clear that in this scenario, stents produce a better acute gain, initial results, but also better long-term results regarding percent diameter stenosis and also minimal lumen diameter at follow-up. In bare metal stents, we were unable to find a significant difference in clinical outcomes in the first year, and we needed to wait for 3 years to see a significant marginal benefit regarding TLR with the use of everolimus-eluting stent. However, in the more challenging subset of patients with drug-eluting stent restenosis, where the drug has already failed, again, stents produce better angiography result that also translated in better late results, as you may see here, minimal lumen diameter, better with everolimus eluting stent as compared with drug-eluting balloons, and this from the very beginning translated into a better clinical outcomes, in particular a reduction in target lesion revascularization. So with some network meta-analysis, you can compare these strategies with historical evidence coming from randomized clinical trials. And if your main endpoint is percent diameter stenosis at follow-up, an angiographic outcome, in this network meta-analysis, we found that clearly everolimus eluting stent is the most effective treatment for this endpoint, diameter stenosis at follow-up, but drug-coating balloons were ranked as the second more effective treatment, superior to brachytherapy and superior to first-generation drug-eluting stent. So from our data, from the RIPS study, it is quite clear that the huge late loss that we can expect from POBA in patients with bare metal stent restenosis can be drastically reduced to 0.14 millimeters in patients treated with drug-coating balloons. So these balloons really work as compared with plain balloon. And this is why we were quite surprised to see this recent study that in fact was very important, as we will discuss later, for the approval by the FDA in the US, where in the States, a plaquetaxel coated balloon was compared with POBA, and obviously the results were in favor of this plaquetaxel coated balloon, and this granted FDA approval, which is very important. Now, regarding the revascularization guidelines, this is the 2018 guidelines. At that time, both drug-eluting stents and drug-eluting balloons got a 1A indication for the treatment of in-stent restenosis. And at that time, we also emphasized that was just consensus about the value of intracoronary imaging to guide and optimize the results of these procedures. As Asim was explaining, this document was also very important because here we emphasize the importance of pre-dilation to obtain an excellent result before using a drug-coating balloon, and obviously we need to target for a less than 30% diameter stenosis, no significant dissection, good flow, and in case of doubt, FFR, as you may see here, can be of value. Now, the most comprehensive and better study comparing stents, drug-eluting stents with drug-coating balloons is this study, the Daedalus patient-level meta-analysis. You may see 10 randomized clinical trials, nearly 2,000 patients, and here drug-eluting stent proved to be superior regarding target lesion revascularization, a clinical endpoint as compared with drug-coating balloons. Please notice that these in Kaplan-Meier curves, target lesion revascularization were better for everolimus eluting stent, but there was an interaction according to the underlying metal, underlying type of stent. So the results were similar with the two strategies in patients presenting with bare metal in stent restenosis. However, there was a clear benefit for the use of drug-eluting stents in this study in patients presenting with drug-eluting stent restenosis. However, there was a safety issue in favor of drug-coating balloons. You may see here how after the first year, beyond this first year, you may see how the safety endpoints that were death, myocardial infarction, and vessel thrombosis tend to be higher in patients treated with stents. And this again show a major interaction according to the stent use. So there was this signal of concern with first-generation drug-eluting stent that was not seen when we use second-generation drug-eluting stents. So this is a summary in a state-of-the-art review, and you may see all the randomized clinical trials comparing different strategies in patients with in-stent restenosis. And as you may see here, in the recent years, most of the trials include this drug-coated balloon strategy, which is presented here in light blue. Now, having said that, when DCB should be preferred I mean, we don't know for sure, but perhaps common sense and experience can be of value. I mean, we will select that in patients with multiple underlying metal layers. Perhaps it is also a good idea in patients with resistant stent under expansion, because, implanting another metal layer, if there is a suboptimal expanded stent, can be a major issue. Perhaps in patients when we obtain, as in the case Asim was showing, an optimal initial angiography result, patients with high bleeding risk, patients with in-stent restenosis involving major cell branches, we don't want to put a second jail in these branches. There is some investigators suggesting that it's good idea to use a DCB in patients with first in-stent restenosis. So if there is a recurrence, we can easily use a drug-eluting stent. And as we explained, in patients with bare metal in-stent restenosis, because DCB results are very good in this setting. Now, the second issue I would like to address is the mechanism of failure. So this is again a slide taken from the revascularization guidelines from the European Society of Cardiology, and you can see how imaging is recommended to underline the causes of stent failure. And regarding in-stent restenosis, underexpansion is a major issue, and also we can differentiate with imaging neoatherosclerosis from neointimal hyperplasia. This is a state-of-the-art where we emphasize the value of intravascular imaging. First, to characterize the lesion presenting with in-stent restenosis. Second, to optimize lesion preparation. And finally, to optimize the final result of the selected therapy. As we know, there are several mechanical factors that may explain the appearance of in-stent restenosis, and all of them can be readily identified using IBUS or optical coherence tomography. This is a classical example some years ago of a patient with severe in-stent restenosis with a clear stent underexpansion as the potential cause. However, using optical coherence tomography, we got a much better resolution. And here you can see that in some patients, you can see this nice, homogeneous, bright tissue, neointimal hyperplasia. In other patients, you see this, dark area. You don't see the stent struts farther away, and there is no clear border. So this is a clear lipid area. This is neoatherosclerosis. And in some cases, you can see calcium outside the stent causing underexpansion, but also calcium within the stent. And this is calcified neoatherosclerosis that in some patients can be difficult to tackle. This is a patient with diffuse in-stent restenosis in the LAD, and you can see the waste in the balloon despite the use of very high pressures. There is calcium outside the stent, but there is also calcium within the stent, so there is a diffuse calcified neoatherosclerosis. And in this case, we use lithotripsy to ensure an optimal final result. In this case, we use a second metal layer. When we perform optical coherence tomography after the drug-coating balloon therapy for in-stent restenosis, we always see this remaining tissue, these dissections, that are much better recognized with OCT as compared with IBUS due to the superior resolution. But the beauty of this is that, a follow-up, there is this systematic remodeling of the neointima, and all these dissections are nicely healed. So the question remains whether or not the underlying tissue could help to explain different effectiveness of our therapies, so that perhaps the tissue can differentiate patients that will do better after DCB and patients that will do better after repeat stent implantation. And this is the question that will be answered by the ISR 5 randomized clinical trial. Now, some final issues. One interesting phenomenon in patients treated with DCB is the phenomenon of late lumen enlargement, that basically is negative late lumen loss. This is mainly important in patients with de novo lesions, but is also of relevance in patients with ISR. Is much more frequent in patients treated with paclitaxel drug-coating balloons. And this appears to be the result of both a positive vessel remodeling, so a growth of the external elastic lamina, and also plaque regression. This is more frequently seen when we see dissections at the end of the procedure, and this is associated not only to better late angiography results, but also appears to be related with better clinical outcome. And the other issue that we will perhaps discuss later on is the value of the new drugs in drug-coating balloons. Early studies suggested that the two drugs, Limus drugs and Plaquitaxel drugs, were similar in several scenarios in stent restenosis and de novo lesions. We performed this meta-analysis where we put together 6 randomized clinical trials comparing head-to-head drug-coating balloons with Plaquitaxel with drug-coating balloons with sirolimus in de novo and in stent restenosis. And as you may see here, as compared with Plaquitaxel drug-coating balloons, Limus, at least first-generation Limus drug-coating balloons were poorer regarding late lumen loss, late lumen enlargement, minimal lumen diameter at follow-up, and percent diameter stenosis. However, we were unable to see, despite putting together these 6 trials, a clinical difference. So the two strategies provided in this meta-analysis similar clinical outcomes, including target lesion revascularization with the 2 devices.
Fantastic. Thank you very much. Now the questions have come in. I have one just at the tail end of what you've just told us, Fernando, and that is there seems to be a difference. Not all drug-coated balloons are the same. What is the mechanistic difference between a paclitaxel-eluting balloon and a Limus-eluting balloon, and what are the technical difficulties in creating these and making them work? Maybe Azim can answer that as well. But first, Fernando.
Well, basically, even in the initial experience with drug-coating balloon that were using Plaquitaxel, we learned that not all devices had the same effectiveness. So in the guidelines 2018, we emphasized that not all drug-coating balloons are created equal and a class effect should not be expected. So we know that Plaquitaxel is easily used, and this is the classical drug in drug-coating balloons, is lipophilic. So there is a better capability of entering and being retained and maintained in the vessel wall, and this is why it is used. I mean, in drug-eluting stents, we prefer using Limus drug. There is a wide therapeutic range, and now we got technology that is able to provide a clear data showing that the drug is retained in the vessel wall. I will say that current evidence from these first-generation Limus drug-coating balloons results, the angiography results appear to be poorer, perhaps because they have a little bit less of this phenomenon that appears to be positive, which is late lumen enlargement.
Okay, thank you very much. Azim, anything to add to that assessment?
Just briefly, to encourage our colleagues that when they think of drug-coated balloons, to do exactly what Fernando said, really look at the technology, understand what's the dose of the drug, what is the excipient that's been put on the drug. The excipient is what allows the drug to be transferred, and also how the drug has been put on. And really, we've seen some drug-coated balloons that are no better than an uncoated balloon. So I think that's very important. I think when it comes to the Limus, the challenge has been the drug's not lipophilic, so we've had to put the drug into lipophilic nanoparticles that allow the drug to be then absorbed and stay attached to the vessel wall. And I think we're now seeing some interesting technologies and innovation in the space where companies are even putting more than one drug. So maybe you can dose the right amount of paclitaxel and Limus at the same time to get the best of both worlds.
Excellent. So yeah, watch this space. I think we're looking at a technology in development rather than something that is already at its best, probably. Now we have a question directed at Dr. Azim. Very nice presentation. It starts by Ahmed Saran. This may aspire that DCB is a twin to imaging. Does that mean no imaging, no DCB, Azim?
So quite honestly, in my practice, that's what I do. And that's what my team does, is they don't open the DCB unless they're using imaging. If you look at the data from Agent, this was the first study on restenosis that had imaging in close to 70% of patients, right, to get those outcomes. I would love to say when we design randomized studies that it's obligatory. Unfortunately, we don't want to do that because then it becomes part of the IFU. But my practice, and I think now we have from ESC the guidelines saying it's class 1 for complex lesions like restenosis. I think the practice should be always use an imaging catheter. And honestly, to me, it doesn't matter whether you use IVUS or OCT. I think it's use what you're better at using and what you feel more comfortable using.
Okay, that was my next question, which goes to Fernando. You have a lot of OCT over IVUS, is that correct?
Well, yeah, that's correct. I think imaging is very important and it should be done in every patient with ISR, as recommended in the guidelines. So that is not the issue that imaging should be used for drug-coating balloons, but also if we eventually finish with a stent, is the best thing to address mechanical issues. My personal bias is that with OCT, well, the resolution is 10 times better. You see the tissue and you see all the little details that can be of value. IVUS is good, but the resolution of OCT is superb.
Yeah. And the follow-on question on that, and it summarizes some of the questions that we have on the chat, and that is, on OCT, you see sometimes after treating, particularly treating with a cutting balloon, that's another question that comes up, massive dissections, right? And you don't see them in the angiogram, and if you just did the angiogram, you would probably leave everything alone. It's just a phenomenon, but you leave them alone. Is there any risk involved in leaving dissections of that nature alone? First, Fernando.
Very quickly, so the use of intracoronary imaging is recommended in patients with ISR, but there is no data on how much to optimize, like cutoff areas or whatever. I mean, the problem now arises in patients with de novo lesions, where you see dissections. To me, it is very clear the information is there. So with OCT, you get the information of the lumen gain, residual plaque, and the stent and depth of the dissection. So, but the problem is that we don't have the data. My advice will be that if on angio we fulfill the criteria for a good DCB result, let's say large dissection in IVUS should not be the only reason to cross over to stent. So try to be conservative, but the data will come from OCT because it's giving the anatomy.
Okay. Azim, you had a nice schedule how to treat instant restenosis, and it really mandates to optimally prepare the lesion. And you use a cutting balloon. One of our listeners, one of our audience asks, is it actually safe to use a cutting balloon in a stent, and how do you use it?
Yeah, that's a great question by the colleagues. I think a lot of colleagues get concerned about cutting balloons and can they, rupture a vessel or damage a vessel. So I think it's a valid concern. So I use a lot of cutting balloons in restenosis. I think one of the things I like is often a restenotic lesion can be very fibrotic. And when you try and dilate a normal balloon, it melancedes back and forth. That was actually one of the main reasons cutting balloons were invented initially, was because they grab into the lesion and they stay there. And so you don't get this melanceading. I think there's some data, and we saw it from ISR Desire 4, that maybe if you have bigger dissections or penetrate the lesion, you're going to get more drug transfer. It makes sense to all of us. As to how I use how I use cutting balloons, I look at the vessel size and say I think I would use a 3.5 non-compliant balloon. I usually downsize by 0.5 millimeter. So I'll use a 3.0 cutting balloon, and I tend to go to higher pressure. I don't go just to 8 or 12. I'll even go to 16 or 18. People are concerned about cutting balloons at higher pressure. I think there's more and more data showing it can be safe as long as you undersize by 0.5 millimeter. Okay, that's super important. And remember, it's not pressure that causes perforations. It's size and diameter. So it's oversizing. And so if you don't oversize, they can be used safely.
Okay, and you mentioned size, which would have been the next question. So perfect segue. When we talked about treatment of native vessels, there was a huge emphasis on it works better in smaller vessels because stents are not so great in smaller vessels. It works less in larger vessels, and we don't quite understand why. That was for native. But in the treatment of in-stent restenosis, funnily, the size of the vessel isn't mentioned really. Why is that?
Well, in patients with in-stent restenosis, you can upgrade the size of the balloon according to the reference vessel, and this is much better obtained with optical coherence tomography than with angiography. This is in addition to address, as we discussed previously, all the classical mechanical issues. But there is plenty of growing and new evidence suggesting that when you finish your DCB in a de novo lesion with a dissection, and it's a benign dissection A to B, the results are superior. So perhaps we can use optical coherence tomography to be a little bit more aggressive and to finish the procedure with a better result, but this is ongoing research.
Mm-hmm. And how about the size difference? What do you treat small vessels with in-stent restenosis differently from very large vessels with in-stent restenosis? Brief answer, Azim.
No, I treat it pretty much the same. But again, I'm respectful of vessel size. The one technology I didn't mention is the very high pressure balloon, OPN balloons. Those go to 30 to 40 atmospheres. And again, they can be used safely if you're respectful of size. I tend to undersize by 0.5 millimeter.
Mm-hmm. One question comes twice or 3 times. Can we reuse drug-eluting balloons? Can you apply 3 times, 5 times?
You can. This is something you need to take care. These balloons, if they don't go directly to the lesion, you can lose the drug. And the only way I can use that twice is when the patient is having chest pain, and I go for 30 seconds, and in the same spot, without moving the balloon, I inflate again for another 30 seconds. But you cannot use in several spots, or you cannot use if your first attempt was not good. So I think lesion predilation is very important to make sure that your balloon goes straight to the lesion.
Here we got a really relevant question. Joaquin Castaneda asked, what would be your main recommendation to tackle in-stent restenosis if you do not have imaging, like in resource-limited countries? If you don't have imaging, Azim, what do you do?
Yeah, that's a good question. And, that's a problem many countries face. Yeah. I think I then use other things to try and decide on vessel size. Look at the size of my guiding catheter. I make sure I give a lot of nitro beforehand. And I tend to go stepwise with balloons. So if I think, that looks like it's probably 4.0, it's a mid-LED, but I'm not sure if it will tolerate 4.0, I will then, if I didn't have imaging, I would go stepwise. So I'll maybe start at 3, then go to 3.5. I'll end up using a few more balloons than I would have otherwise. But it can sometimes be challenging because the one thing we've all learned as interventional cardiologists, no matter how long we've been doing this, we are really bad at estimating vessel size. Because you always think it's one vessel size, and you put the imaging catheter, and it's 1 millimeter larger than we thought.
It's always bigger than you think, right?
Yeah.
Fernando, is cost an issue? This was a question about resource. Let me follow up and just mention it.
Cost is an issue, but there is a wide variation in cost. Azim will explain that now the DCBs in the States cost now nearly, correct me, Azim, nearly $6,000. In Europe, it's much less, it's less than 1,000 euros. But the issue is that in Europe, there is also a wide variation in the price of drug-eluting stents, from 800 euros in some countries to other countries with huge amount of PCIs, less than 100 euros.
Right. I mentioned at the beginning the fact that this year the FDA approved drug-coated balloons for the treatment of in-stent restenosis, but also there was a change in guidelines. I will dive a little bit into that and discuss with both of you some of the backgrounds. And with Azim, I had some interesting discussions, some eye-openers, really. So we've seen this 2018 ESC EACTS guidelines on myocardial revascularization. They were not repeated as such. The next one is on chronic coronary syndromes. But there, DES are recommended for the treatment of in-stent restenosis of BMS or DES, a 1A, meaning, full evidence, several randomized trials. And drug-coated balloons are recommended for the treatment of in-stent restenosis of BMS or DMS. So same. And that's why in most of the review articles you still read there is a 1A recommendation for drug-coated balloons for this indication. But then 2024, this year, the guidelines for the management of chronic coronary syndromes showed DES is recommended over drug-coated balloons for treatment of in-stent in DES restenosis, so not in BMS, in DES, with a class 1A. And the individual recommendation went. And there's a long text explaining it, and I'll read it out, and then we can discuss. Drug-eluting balloon angioplasty and repeat stenting with DES were equally effective and safe in treating bare metal in-stent restenosis, but drug-coated balloon angioplasty was less effective than repeat paclitaxel DES implantation in treating DES in-stent restenosis. However, at 10-year follow-up, there was no difference in clinical endpoints between drug-coated balloon angioplasty and DES implantation, whereas both were more effective than balloon angioplasty in preventing target lesion revascularization. And everolimus DES was associated with better long-term outcomes than drug-coated balloons. There's a lot of players here, and it becomes a little bit difficult for non-experts. Fernando, first, your view on this. This is too quick, sorry. Going back, your view.
Okay, so when we write the 2018 recommendations, the data suggesting that drug-eluting stents were superior regarding late angiographic parameters and also target lesion revascularization was already there. But I think at that time we also acknowledge the great effectiveness of DCB as compared with other technologies. So we overall consider that both strategies could be used. Now, in the current guidelines, they selected patients with drug-eluting stent restenosis, even though we still see patients with bare metal stent restenosis. And there they emphasize, in the two tables, they emphasize that in a patient with drug-eluting stent restenosis, drug-eluting stent should be preferred over a drug-coating balloon with 1A. So this may be seen as a very strong recommendation. I think in the test, the guidelines are quite sensible and quite balanced, but this recommendation that if your target is reducing target lesion revascularization is correct, can be misleading for many people because, eventually if there is a patient with some stent layers and recurrence, well, just putting another stent is not the most elegant strategy, I would say, and there is plenty of data suggesting that drug-coating balloon can do a fantastic job. So I think, the guidelines are correct and we should respect them because they are based on data, but that data was already in the prior guidelines, and I think to make a major change in recommendation, you need very strong and robust evidence. And the only evidence is that coming from this very important comprehensive patient-level meta-analysis, Daedalus, and I respect that, but I think this can be misleading for some people.
Azim, in the US you now have approval, but that was achieved with comparing not against the drug-eluting stent, I understand, but comparing against balloon angioplasty.
Yes, absolutely. So, when you do a study in the US with the FDA, and it's a randomized study to approve a new device, you have to randomize against what's the standard of care, right? So what's been the standard of care in the United States for restenosis? Well, actually, I don't know if you know this, but brachytherapy has still been available in the United States, and that's been one of the therapies. But for most operators, actually, it'll just be, dilate the lesion as well as possible, use POBA, cutting balloons, maybe even laser, try and get the best angiographic result, because most operators don't like putting a second stent layer. Add to that there is no stent actually approved. I'm not sure about Europe, but in the United States, there's no stent that has an indication for restenosis, which means there's never been a study done for approval of a stent in restenotic lesions, right? So when we did the study, you had to then compare against standard of care. Standard of care actually ends up being just POBA. And that's why it seems strange to Europeans that we would do a study against POBA, but that was the standard of care. Now things have changed, though, because the study was so positive that now the new standard of care is a drug-coated balloon. So all the new drug-coated balloons that want to get approval will probably have to randomize against the approved paclitaxel drug-coated balloon moving forward. And like I say again, there's no stent approved for restenosis in the United States.
So that's an amazing insight. So, you won't have the same guidelines for that exact reason. Fernando, do you think there are trials ahead that may change the views and may cement our view?
Yeah, as I briefly presented, there is a trial where the tissue causing the obstruction, the tissue causing stent restenosis, will be the issue to be discussed whether or not the relative efficacy of drug-coating balloon versus drug-eluting stent is superior. And in patients with de novo lesions, there are some important randomized clinical trials, power for clinical endpoints that will be presented next year probably, and will confirm whether or not in patients with, not selected patients, but rather a broad population of patients with de novo lesions, including large vessels, drug-coating balloons are non-inferior to drug-eluting stents.
Fantastic. So, we're at the end already. I think we could have discussed much longer. We're at the end of this hour. It's your turn again. DCB should be first choice over DES for in-stent restenosis. How do you feel now after you heard what we've just discussed for the last 58 minutes? So it's coming in. Ooh. It's moving. You can see it on the chat, I believe, but I'll read out the numbers in just a second. I'll give you another 30 seconds for that. But I can tell you, DCB is still winning by big margins. We'll get to the final score. Ooh la la. Right now, we leave it at that. 90 to 10%. So 90% in favor, 10%, 9% against. We convinced 4% of our colleagues. So you've done a good job, dear colleagues. And with that, I say a little summary of what we've just learned, what I learned. I think it is clear, in-stent restenosis is a clinical problem. It's not something that has gone away with drug-eluting stents. We're treating more and more complex lesions. That's another addition. There will always be in-stent restenosis. In-stent restenosis also is not benign. We believe that if you have it available, instant restenosis mandates imaging. And drug-coated balloons should be used after careful lesion preparation, after identification of the nature of the instant restenosis, and then careful lesion preparation. And we believe there are trials underway that will further provide evidence for the benefit of the use of drug-coated balloons in this field of instant restenosis. Until then, our practice will be guided by individual patient decisions and hopefully for the benefit of our patients. I thank my two guest speakers, Azim and Fernando, and goodbye to wherever you're watching in this world. This is also, of course, available online afterwards. Goodbye.